it does.
It's kind of like the same as the oblique hand.
It really kind of is the same degree of obliquity. It's 45 degrees. So, all right, here we've got a patient that's got a really, really sore hand. He's got a very sore hand that he can't really move. And so what we're going to do is we're going to take a picture of this patient's hand, 3 views, and then we're also going to get some cone down images of just his 3rd digit. All right, Miss K, let's see your stuff.
Okay. I'm just going to move the center at the MCP joint.
That's correct.
And try to get those fingers as flat as you can.
All right, your patient's trying to get off the collimated field.
Yeah.
Just bring your finger in a little bit.
Okay, we're going to put a marker on there. Where should we put our marker?
Lateral.
Medial or lateral?
Lateral.
Lateral is good. Okay, now, when the patient is in this PA position, I'm sorry, we're doing this PA projection. Very good. Okay, I am the worst to put my marker over by the patient's pinky, thinking, oh, that's lateral. But it's really not. It should go close to the thumb because technically yeah, exactly. In anatomic position, the thumb is lateral, so that's where your marker should go.
Sometimes you have to do it to like measure this. Okay.
All right, PA hand. Now, we got to do an oblique hand.
Oblique. So could you please lift your hand up on your pinky 45 degrees?
All right, does that look like a 45-degree angle? Fingers are all nice and straight.
Yes.
Thumb parallel to the image receptor.
Yeah. It is now.
It is now, yeah. All right, that works.
Okay. Hold still.
Beep.
Lateral.
Yep. All right, now, fan lateral.
Okay. Make a karate chop with your hand. Bring your fingers together and kind of make an okay sign. Squeeze your fingers in like that.
Pretty much everybody on the planet knows the OK sign.
Yeah.
Yeah, so you can just ask your patient to do that. Try to have a little bit of space between the thumbs, because some people, when they do the OK sign, they want to touch their thumb and finger together, which, you know, that's probably fine, but I try to always make sure there's a little bit of space between there. Okay, now, is his hand truly lateral? Okay. Miss Hope is shaking her head. She says no.
No.
We're not lateral. There you go. Try to get those knuckles on top of one another. Okay, fan lateral. And all of the shadows of his fingers are all in the light field. Very important. All right, very good.
Which one?
Okay, we've got a patient comes in today and they've got a hurting finger and it just happens to be the ring finger of their right hand. So this is the 1, 2, 3, 4th digit.
This one right here.
That's the one. Okay, if you just hold up your ring finger by itself, it looks kind of like a vile gesture, but it isn't.
Put on PA.
Yes, please.
Okay.
Now, whenever would we do an AP finger?
If they couldn't do.
Yeah, exactly. If you had a patient that had like some serious trauma and you couldn't really get their hand into the PA position or the PA projection, then you could do this AP. All right, now whenever we're coning down to the finger, we're going to have our central ray. Central ray is going to be at the pip, exactly. The proximal interphalangeal joint.
Like that.
Yeah, just like that. Okay, where can we put our marker on this?
At the top.
There you go. Just make sure it's you got some space between the marker and your patient's anatomy. There you go. What if the marker is overlapping the finger?
To repeat.
That's
Going to have to repeat. Yeah, we can't put our marker in the anatomy like that.
Okay.
Okay, now let's get an oblique on that same digit.
I'm gonna turn your hand.
Okay, so our obliquity is going to be about 45
Okay.
degrees. Okay, now that finger doesn't look very straight. Are you sure is that finger straight? A little OID is okay, if it means that we have open joint spaces.
Can you try to straighten them as much as possible? There we go.
Okay, cool. On the video, it looks like that finger is like sloping down.
This one?
Uh-huh. Can you hold that pose for me, ma'am?
I can try it.
Okay, see how straighter that is? Okay, all right, hold still, just for a few seconds. Beep. Okay, you can relax.
And lateral.
Yes, please. Necesito un lateral.
Can you kind of go like that?
All right, once again, making sure that finger is parallel to the image receptor as much as possible. That actually looks pretty good. Okay, so you've got the pinky back out of the way. You've got the second and third digits as out of the way as they can get. Hang on a sec, I want to try something. I don't know if that's going to help or not. Can I use this popsicle stick to move those fingers out of the way? Kind of separate that a little bit? I don't know. Okay, it's possible to use popsicle sticks and tape to create a little more separation there, if necessary, but I think what you've got is probably okay.
Okay.
All right, excellent. Very good work. All right, it's a very, very unfortunate story. This young lady's thumb got stepped on by a cat. And so now she's here after being heavily traumatized by the feline perpetrator. We need to x-ray her thumb.
How big was
What kind of projection would you like, sir?
What's our protocol say? AP,
AP projection.
oblique, and lateral.
Yes. So
All
we're
right.
going to start with an AP.
Let's do it.
So ma'am, if I can get you to kind of turn your arm, there we go.
It's hard to describe, isn't it?
Yes, it is.
It's like, how do you verbally tell somebody to invert their hand like this? You really just have to act it out for them. Of course, it helps if your patient already knows the deal.
Marker.
All right, where's that central ray supposed to be?
The MCP joint.
Very good. Do you know the difference between the dip and the pip on the thumb?
Yes.
Distal.
One refers to distal, one refers to proximal.
Isn't it just an IP joint?
Ding, ding, ding. There's only one.
Oh, for the
There's
thumb.
really not a, you know,
For the
the
thumb.
dip and the pip are the same thing in the thumb.
Mm-hmm.
All right, but we're going to be centered. Okay, so we've got the thumb in as true of an AP as we can get it.
Mm-hmm.
This is a supine thumb.
Yeah.
Well, you know, kind of it is.
Yep.
All right, very good. Just make sure that her pinky's not in the way.
Yeah.
Our patient's getting lazy.
There we go.
You okay, ma'am?
Yeah.
All right.
Beep.
That thumb really got stomped on. Okay, now,
Yeah.
for our next picture. Oblique thumb.
Yep. Just set your hand down like that.
The most difficult image in radiography. Fun fact, do you know which radiographic image is most often repeated worldwide?
A thumb.
Highest repeat rate. What was your guess?
A thumb.
Thumb. Good guess, but no.
Is it the Y shoulder?
You would think, because darn if I don't have to repeat my Y all the time. All right, we got a thumbs up on the oblique thumb. Okay,
The lateral knee?
it's not. It's actually the pelvis. The pelvis has the highest repeat rate of any image, which I didn't know that until I was doing some research a couple years ago for a presentation on repeat x-rays in, you know, keeping track of repeat x-rays in digital imaging. Because, you know, once upon a time, everything was on film, right? And so if you had a bogus picture, what'd you do with it? Well, you threw it in the trash can, right? So you come by later on and you see that the trash is just like overflowing. It's like, well, what the heck? You know, who's doing all these repeats and, you know, why are they repeating things? So you could easily do an analysis just by going through the garbage can. Fast forward to today, everything's digital and not everybody tracks their repeats. So, you know, for those sites that do, doing a repeat analysis can be a very, very valuable tool for training. You know, it's not that you're going to penalize somebody for having too many repeats, but like Ms. Catherine was saying, shoulder, like Y-view shoulder. If we're having a lot of repeats of the Y-view shoulder, well, how come? Is it that we can't palpate the anatomy, or are we just, you know, we're operating off of some misconceptions about how this thing should be positioned?
Mm-hmm.
Okay, that is like my Achilles heel. I repeat the heck out of some Y-view shoulders. It's like I don't know what in the heck I'm aiming at. Okay, now the next thing we're going to be doing, because we got to complete this requisition, we still need a lateral thumb.
Let's try to get this thumb on its side. Excellent.
Okay.
Oops.
Hey, see if you can get that thing in the center of the image receptor.
Okay.
You're, there you go. Just say, all right, I'm gonna move this film underneath you. Don't let me move you. Because you basically got your patient positioned, right? Man, that marker is close. Okay, check this out. We can make use of something called off-focus radiation. If we have our marker like that, it's going to be like on the edge of the field. It's still going to be very visible.
Centering at the MCP.
Correctamundo.
Trying to get the thumb as lateral as we can.
All right, and that thumb looks pretty lateral. All right, ma'am, can you hold that position for me? All right, hold still. Okay, you can relax and breathe normally. All right. This patient was having real trouble getting the lid off a bottle of beer and wound up spraining her wrist.
If I could get you to just bring your hands forwards this way.
Oh!
I think you need to go ahead and save this image.
Okay, and make a loose fist. Back. Good.
All right, how come we get them to make a loose fist?
To put their wrist as close to the image receptor as you can.
Very good. That's going to help those carpal bones be nice and close to the image receptor. Okay, so we're centered to the...
The mid-carpal.
Exactly. We're
area.
centered to the carpal bones.
Okay.
All right, very good.
I just used your marker.
Now, you could totally cone down side to side a little bit and just kind of put your marker in the edge of the light field there.
So, oblique.
Yes, the next thing on our list of things to do is an oblique wrist.
Okay, you can straighten out your fingers and turn your hand up at a 45-degree angle. We good?
Yeah,
Yeah, okay. Hold still.
that's good.
Okay. Now, can I get you to make a karate chop with your hand? Good. And
Everybody pretty much understands that concept too. If you know, because we've all seen those old karate movies, you know, where they were like
Yeah.
chopping people in the neck. I don't know if that's really very effective as a fighting technique, but
Probably not at all.
karate chop. On the Andy Griffith Show, Barney was always...
His one bullet.
All right, so have we got our radius and ulna on top of one another? Can you feel those bones? Wonder, is it more common? Okay, say that we don't have a true lateral and our radius and ulna are off kilter. Wonder, is it more common for the patient to be rotated too far externally, like this? Or are they most of the time, are they rotated so that the ulna is posterior to the radius?
I would
I'm
say
not
the latter.
sure. I would think that.
I would say the latter, yes.
Yeah. Feels good how I had it.
Yeah, you had it good until I came along and messed it up. All right, very good.
Cool.
All right, so finger, thumb, hand, wrist. We got it. Okay, we're ready to do some extremity x-rays.
Excellent.
All right. I couldn't have said it better myself, sir. Okay, now for our next trick. Nothing up my sleeve. We're going to be doing some x-rays of the hand phantom, and we're going to be doing hand and wrist x-rays, right? We're going to be doing hand and wrist x-rays
Because he knows I don't like
on
to
the
know.
hand phantom. Okay. All right. Nobody has to have their face on my video if they don't want to.
So like for my retirement, the joke is whenever I retire, all the pictures that have been taken in the program of me will be this. Isn't that right?
A lot of them are.
Like I'm really fast too, and I have peripheral vision, right? I
Is it
see
going?
the camera and I'm like,
Yeah.
Here's the control panel.
Okay, thank you very much. All right, now we need to set a technique on said control panel. What do you think we should use?
60 and 1 point. What are we doing? A hand?
Hand, yeah.
60 and like 2.
Okay, 60 and 2, I like it. All right, now Ms. Berger, do you want to use the AGFA system or do you want to use the Fuji system? Either way is fine.
is the Fuji, the monitor fixed?
Yeah, we got a brand new monitor.
Oh, when did that happen?
Like 2 weeks ago.
Yeah, we can use the Fuji. That's a lot. It has less opportunity for getting stuck.
Truth. And we have
Oh yeah.
brand new 8x10s, boy.
All right.
Oh man, that is all blurred out.
I believe I've selected
So
the
what,
appropriate technique.
so what I'm gonna do is I'm gonna get one person to help me, so they'll know what we're doing.
Okay.
So I'm gonna get you to help me,
Okay.
and then we'll come up here and then we'll figure out which one of these. So one of them is on the next page. One of them is going to be exposure 1 and one is going to be exposure 2. But I left them blank because we're gonna figure out what it is. And then I gave you some box where you can write your little notes in your own words what's going on. All right.
Okay, so here's the setup. We've got this hand phantom that we're going to be taking images of. But Ms. Berger's going to pull the curtain on us so we can't see what's happening. Hey, now. This is our X-ray lab. And in our laboratory, we have an AGFA reader for AGFA CR. And we also have this very handy Fuji reader. And so whenever we're doing our images, we can basically just choose whichever system we want to use. We also have a DR system, but except for I don't feel like firing that up right now, it's kind of a pain. And if we're just going to do some quick and dirty x-rays, there's no need to go through all the hassle of getting the DR plate up and running. Okay, so originally I set up for a hand, oblique,
We're doing a wrist oblique.
and lateral, and wrist oblique, and wrist lateral. But we've had a minor change of plan.
And then,
Mr. Lee, will you help her? since
I
you're
will indeed.
It's,
Okay, now you said this thing is actually a wrist,
yes.
but we just don't know what kind of wrist.
It's going to be a lateral or an attempted lateral.
Okay, so we'll run it as a wrist lateral.
Okay.
All right. Ms. Hope, if you would do the honors.
I'll do it.
See this little bar right here?
Mm-hmm.
That goes in just like that.
I haven't had to do this up near here.
Oh, you haven't?
Uh-uh.
Oh,
You'll
okay.
do that Wellington House.
Okay.
Oh, that's true. So, I'm sorry.
It's okay.
Yeah.
Well, some of
I
our
didn't-
sites
I'm
have
sorry.
CR
It's okay.
and most of them now are DR. So
Yeah, there's 5 sites that have CR.
Really?
So it's Wilmington Health, no, which
No, it's
is-
the Wilmington Healths, and the orthos.
Okay.
and- just one more off the top of my head. Oh, all right.
Okay, so what do you guys think of this image? Can you see the radius and can you see the ulna? They're stacked on top of one another?
They are.
They are. I mean, I would totally pass this image. But if there is any rotation here, which direction is it?
It's going back a little bit.
What she said. There's a little external rotation, isn't there? Now, how come Ms. Madison was thinking that?
It's the position of the radius and the ulna.
Is the ulna anterior or posterior to the radius?
Anterior.
It's a little bit anterior. That means that they had the patient's wrist rolled back a little too far.
And you can also,
But, go
look
ahead,
at
I'm sorry.
the carpal, the metacarpals. Look how, you see how you can see more? But yes, the radius and ulna are definitely, because she picked, I
So
told her.
that would be
I'm confused
the
now.
blue, no, that would be the yellow, right?
So when you're so which one was this one? Which bone is anterior?
The ulna is anterior.
So which one, out of which ones, I know it's probably, if you can see definitely when you walk up closer.
Mhm.
So which one did you think it was?
The yellow?
Yes, the yellow. Number 2, so the second exposure, that would be number 2. So your descriptions can be, like think about how you would put into words, like the ulna is more anterior to the radius. The patient's palm was more supinated, or the back of the hand was closest to the image receptor, something like, because it was really slight, Hope, wasn't it? It was just a little bit, just a little bit.
Yeah, I would show that image to the radiologist. It's not perfect, but
But the thing is, when she positioned it, it actually looked a lot worse. It
Right.
actually would look like it'd be more dramatic. But but also think about, look at that pisiform.
mm-hmm.
Does everybody see where the pisiform is on the image? I'll say, and wait till Hope and Ben get to see it. Do you see the pisiform
Yes.
on
Yes.
on that hand? So imagine, you can also look at that. So everybody know where your
Mhm.
pisiform is?
Mhm.
It's like right here. So imagine that when your hand is back, that you should see that pisiform. So that is also, I mean, that's another
Yeah.
critical thinking kind of a thing. All right, who wants to come? Obviously, we're gonna do the other one, but I'll let them position.
All right, let's do another one. Who's a volunteer positioner?
Ben,
Yes,
you're
ma'am.
next. And then I'll let somebody else do the exposure.
Ben, you've been voluntold.
Oh, I need a cassette.
Oh, here,
Alright.
here, take one of mine.
Okay, thanks. All right, now you're gonna do the opposite. So.
Okay, this cassette was donated to us because it came from a site that didn't use it anymore. But this thing looks brand new, doesn't it? It doesn't have a scratch on it. This thing looks like it just came from the factory.
It's cute.
Beautiful. Here's something else. Okay, these Fuji cassettes, and I wasn't 100% sure about this. This is in Fuji's advertising material. They say that the 8x10 cassette is actually higher spatial resolution than the 10 bys and the 14 bys. And so I did a test with this thing using a line pair test tool, which we have in the laboratory, and sure enough, this thing shows like an extra line pair per millimeter higher resolution above what the 10x12 can do. So Fuji's advertising is not false. If you want really good spatial resolution, then this 8x10 cassette is the way to go.
If you're trying to get that in the camera.
I
you
know,
can
that would have
feel
been a
it.
perfect commercial.
There you go.
Fuji.
Her guns in there.
8x10, the choice of champions.
You need to put that in your video.
I know, people think that I'm stumping for Fuji all the time, but you know, their equipment works. It's reliable as
Have
heck.
you ever eaten at Fuji?
Have I done what?
There's a restaurant called Fuji.
Really? No, I've never eaten at the
Never
Fuji
heard of it.
restaurant.
It's in Goldsboro. Back in
Okay.
Fairfield.
Well, I tell you what, if the Fuji restaurant is anything like their cassettes, then you can count me in. Is it like a Japanese steakhouse?
Exactly what it is.
Okay. There used to be a Japanese steakhouse out close to where I live.
Wait, wasn't it like Fujisan or something?
It's like,
What?
is it
Fuji-san?
Fiji Express? Is that what you said it's called?
Uh-uh.
I don't know.
There's
Okay.
one in like
Fuji.
Briar Creek.
Japanese
out in Raleigh,
steakhouse.
it's like
Never
Fujisan
mind.
or something.
That one that was close
It's
to my
probably
house
same
was
thing.
expensive. Oh my gosh.
I like going
It
to
was-
Miyabi's down there at Myrtle Beach. I don't know
Yeah.
if her, it's the
Miyabi's
steakhouse,
so
yes.
good.
Yeah, but how
It's
much does,
expensive.
I was gonna say, how much does it cost me to eat there?
It's like, what, $25?
Yeah.
I go during the early bird, but they're not even having that no more. And it's still like $22 just for teriyaki chicken.
But good
Wow.
hibachi is good.
Yeah, it's really good.
Yeah, the hibachi grill is more my speed.
So, this time will help, since I didn't realize, I have to just tell you, because he's at Dosher, so he hadn't done this either.
I don't know what happened to me, but like the last
Feel like
three
this
is
times
Julie?
I've eaten hibachi, I've got
Yep,
sick.
that's it exactly.
Oh, really?
Was it the
And,
same place?
There you go.
I was going to say, you need to change that place, but never mind.
And before you, the way the
Maybe
Fuji
you don't
system
react
works,
well.
you have to
My
highlight
friend
your
got that
The one
exam.
you're- yeah, the one you're wanting to-
Yeah, because if you don't, then it'll give you an error message.
I was going to
And,
say that if it makes
assign it a
I
slot.
love it.
mhm.
It's like-
Now, that's one of the
Well,
things
that's
about the
my favorite, and,
AGFA,
like,
you
I
can
grab
just
it
throw
and
a
Oh, yeah.
cassette in there,
Yeah, like,
and it will just automatically
Yeah.
register whatever was the last exam you were doing,
Yeah,
Mhm.
it just makes
and then
it
you can
stop.
change it later if you want
That's
to.
actually so tragic.
It is.
It really is.
And don't get
Don't
older,
worry.
guys.
Don't grow up.
Let's see how exaggerated. Oh, yeah,
Yeah, that's pretty exaggerated.
It is. So we know that it was supposed to be a lateral. But I could say that is an over oblique, right? But now look at the radius and the ulna. Which one is more anterior? The radius. That's definitely more exact. I'm telling you, we did the same exaggeration, same like degree of exaggeration, and hit that one is just interesting how it's put together in there.
Yeah.
That's supposed to be lateral?
Yep.
Okay, this is what my laterals usually turn out like.
Yep.
So is it this one?
Yes. I mean, it doesn't look exactly, but that picture, the blue picture, shows you that the radius is going to be more forward.
Should we just push this through and hope that the rad doesn't catch it?
So like
Maybe
your
they
words
won't
could be,
notice.
radius is more anterior,
Palm is
the palm is
pronated.
closer to the image receptor, more pronated, something like that. Things like that.
Okay, here's what we're gonna do.
And now, yes.
In order to save myself from having to repeat this,
Oh, okay, that's gonna fix it. But then that's an
Sweet.
over oblique.
Yeah.
So now we're gonna do a perfect lateral. We're gonna try to. And no pressure.
all right, who
Record
wants to
leg,
step
too.
forward and do the perfect lateral?
We're gonna see. And, I mean,
Sandra,
oh God.
Sandra volunteers.
Oh, God. Yeah, the marker would be more.
Yeah. I have to repeat it anyway, Miss Lee.
All right, we're gonna see. But we're not gonna put any pressure on.
No
Because
pressure,
we
no
know this
pressure.
is not a real hand.
The skeleton is still like that from like 2 weeks ago. See the skeleton? See how I positioned him?
I can't believe no one's moved it.
I know.
That was like
I
a
know.
while ago, wasn't it?
Yeah.
Okay, just in case the viewing audience wants to know what he's talking about. Okay, there's our skeleton. Skeleton abuse.
Handsome.
Who stole the leg?
Got a handsome underbite.
I got a feeling I know who stole the leg. I had a student one time that had an underbite, and she talked just like this.
What if she's watching the video?
Oh, that would be terrible. All right, if you're watching this video and you're a student with an underbite, then I totally apologize. But darn, you cracked me up.
All right, I'm gonna get you and we'll run it. doesn't come out perfect, because it's, as y'all, well, y'all two saw, it's hard to see if it's perfect, but. And then we'll do oblique, 2 oblique and not oblique, enough hands.
2 oblique.
You're trying to make a song, I can see it.
Oblique.
I can see
What
it.
rhymes with oblique?
To go this way or this way?
2 sheep.
Oh. Wait, what's this? 3 straight, yeah.
Monique.
Now you're coming up with a
Yeah, I am. Oh my gosh, now it's gonna be perfect.
All right, what do y'all think of this the perfect wrist?
Well, it's not perfect.
It's getting there.
Okay, let's compare. This is the perfect wrist, and then here goes the 2 oblique wrist.
No, that's wrong.
That's
Yeah, that was the external oblique.
Sorry. I thought I didn't know if anybody was looking. Sorry, I was just looking. I didn't have my glasses on.
and it's rotated
Take a look
out
at
Still-
a little
that.
yeah,
bit.
so it's
And
still
you can just come
external,
in
right?
a little
When
bit.
you touch the top one
Yepper.
and then the bottom one, I still think that's still better.
That'd still be externally rotated though, a little
It's
bit,
so
right?
slight.
Okay, yeah.
But if you, you can see how much of the radius I mean, it's still,
Yeah. Okay. The one that was deliberately rotated. See, we have a gap right back here between the cortical bone of the ulna and the radius, which we could measure. And see, I mean, there's still a gap there, but it's much more narrow
You see
now.
that?
Yeah.
Yeah.
Mm-hmm.
so Sandra is like, so it was hard, like it didn't look perfect. But I still think that's really good.
It's hard to get a wrist X-ray exactly perfect.
It is,
I mean, you get it as close as you can.
but if a real person, it's a lot easier than that thing. But so just thinking about the radius, when the radius is more forward, if you notice on your thumb, that's the one that the palm is down. So that's why I gave you some good radiographs. That way you can kind of visualize that. All right, Mia, you're going to we're going to go do an exposure. I'm not going to tell you what we're doing.
All right, now for the next exposure.
All right, moving to the next one.
And we don't know what this is going to be. It's going to be a surprise.
It is. It's up to Mia.
Mamma mia.
Yeah, I never experienced quarantine. I still had to go to work.
Yeah, no, we shut down. We shut down about like, okay.
Yeah, it's like.
Well, you worked
Okay, here.
which one do you work at?
The one in Leland.
I tried to get him to go like maybe a month after all the quarantine stuff happened.
So it goes like this?
Yes, ma'am.
And when I called, they were so busy, right?
Yeah.
And it took me like 25 times, I'm not lying, to try to get in. And they said it would probably be an hour and a half. I was like, no, thank you.
Yeah.
After I was
It's like all to go now because, you know, you have half capacity and then everyone's like, oh yeah.
What is it?
to go where she works. She was
Okay, now if I come to your restaurant and I want to sit in the dining room, then,
Yeah, if there's room.
okay.
What restaurant you work at?
She works at Cape Fear Seafood in Leland.
And
All right, all right, y'all, what do y'all think? Which one of these, when you look at this, what do you think? Like, imagine how that hand was.
Definitely oblique.
Huh?
oblique.
It is, but is
It's extremely
it
oblique.
perfect? Or too oblique or not oblique enough?
Too oblique.
So explain why that, your answer is right, Madison.
Because of the spacing between the
Metacarpals, right?
Ding, ding.
So like that one, like in words, would be that, you remember on the critique, you're supposed to have the bases and the heads of the third, fourth, and fifth metacarpals superimposing and equal distances between the shafts. So that is 2 obliques, so that was more than 45, going towards that 90. Almost looked like that lateral that Ben did.
That would be the.
Yeah, actually it does, doesn't it?
Yeah.
Or is the.
So that is
Sure does.
2 oblique.
So is that this one?
Yeah, I would have to. see the
Yes,
last one.
yes, the last image. That would be the last image on there. I mean, that's close to it. So your words would be 2 oblique. Look how much the radius and ulnar are superimposing each other as well.
So this one? Or this one?
That one, the last one. Oh, yeah, the one all the way to the right.
Okay.
Sorry, the one all the way to the right. So, because we're going to compare one that's not oblique enough in the PA, because on the PA, the radius and ulnar are not touching hardly at all. Mr. Lee is having a great time over there.
I know. Dancing to music that only I can hear.
All right, Kat, we're going to do the other one. May not be what you think.
Don't know what you got till it's gone. We don't know what you did. What have you been doing in there?
She's not going to tell.
Getting up to no good, I imagine.
Of course. I use the real one that the hand is broken, but it doesn't have any radius and ulna on it, so it wasn't going to help me.
I wish I could find the missing fingers from that
I thought there
hand.
was one in that drawer, only one. I don't know where the other one went. Look at that. Do you see how that's, do you see the symmetrical, the spaces between the third, fourth, and fifth? There's symmetrical space between the third and the fourth and the fifth?
That means it's way too oblique, right?
No. Perfect.
It's an oblique.
It's the perfect oblique. So that's actually going to be the last exposure. Told you, like, I was tricking y'all up. So that is actually good. So look at how the radius and ulnar are just superimposing just a little bit. Because on the PA, I'll take a picture. But on the PA, so it's called the last exposure. So it's the second image. But it's a good image. It's a 45 degree because the bases and the heads of 3, 4, and 5 are superimposing, and there's equal distance between the shafts of those. And all right, Madison. I'll let you finish writing. She's got your cassette.
Do I forget your cassette?
Might need that.
I know, you can make a lot more images with a cassette than you can with that one.
What did she say about the heads of the metacarpal?
Oh, 3, 4, and 5. The heads and the, oh golly.
But the shafts, right?
The shafts are supposed to be equidistant apart,
Yeah.
and the base and the head's supposed to be somewhat superimposed.
Okay.
The first and second metacarpals they shouldn't be, they should be just out by themselves. They shouldn't have any superimposition. And joint spaces are open, so the hand phantom was parallel to the image receptor.
You don't know which one she did.
Don't know what she did till it's run.
I love
That's
that
back in
song.
my day. Some of it, does everybody know what song that
I'm a
is?
balladeer.
Like some people look like, yeah. I think they came to UNCW when I was in high school and I went and saw them. I just can't remember. I only have been to like maybe 4 concerts in my entire life. Okay, I'm gonna ask a stupid question. Is that Cinderella?
Yes.
Okay, then they did, because they came down, he came down on a piano with blue lights and fake snow. I remember that.
I was in Hammerjacks one night, and the lead singer of Cinderella was in there, and he was wasted.
So what do y'all
My
think?
gosh.
It's not oblique enough.
So it was supposed to be an oblique, and it wasn't quite 45. Now, why do you think that? Look at the work, look at everything, and kind of figure out why. Like, what made you feel that way?
The heads of the 3, 4, and 5 aren't like super heavy.
Correct. And you can see, do you see how there's starting the curvature? The phalanxes, they're not quite symmetrical, so you know they're obliqued. And then one side looks a little straighter, and one side looks a little curvier.
Mhm.
And then look at the radius and ulna, they're starting, it's just slightly on top of each other, not a lot. What are you gonna do?
Just something I'm curious about.
Okay.
What did you say was start?
Yeah.
What?
The heads. What did you say about the heads?
Well, the base and the heads are not superimposed. Just like, so on this one,
Hey, Bill, would you hit the expose for me?
it's like you see on that one, the bases and the heads are like right there. And then, I don't know where he was. Was it here? Yeah. They're not superimposed at all. And then the radius and ulna, like compared to, you can see how that obliquity, is some superimposition. Hold on. Talking to him. And
There was
it's
some
like,
superimposition.
okay, all right, hold on.
Dawn day.
And then you said another term, something.
Concave?
Yeah.
So like on that one, so I'm gonna do a PA hand in just a second.
Okay.
So on a PA hand is bilateral concavity. That means both of those phalanx have bilateral concavity. You can see here, they don't. Now I'll go do that exposure. So you can see it while you're,
Okay, I just did a PA hand
oh.
because,
You
well,
lady-
I didn't know you were going to do it. I didn't mean to steal your thunder.
No, I'm glad.
I just wanted to,
Now we
just
can
wanted
have
to
a
do a true
comparison.
PA for comparison
Yes.
purposes.
So now, look at you can see that the radius and ulna are barely touching. We're not-
Okay, there's the shallow oblique, and here's the PA. This was just the phantom, just laid down on the image receptor.
So the radius and ulnar, what is that joint space called where the radius and ulna are touching?
The radial.
Radial ulnar, so it's the distal
The
radial
distal
ulnar, yeah,
radial
because there's a
ulnar.
proximal one. That's the distal. And so everything's fused together. But look at the thumb. Don't you see how the thumb looks different than the fingers, don't they? Because remember, the thumb is naturally in a what position?
45
Oblique.
degree, yeah.
Yep. So you can see the radius and ulnar are just kissing each other, like just touching. And then, Mr. Lee, will you do that good oblique that Kat did?
Shoot.
Yeah.
Was that it?
Yep.
Yes.
Do you see how now it's starting to superimpose? So the more superimposition of the radius and ulna, the more is going towards lateral. Like, you know what I'm saying? So when it's PA, it's not touching or it's barely touching, like just kissing it like side to side. And the more you rotate up to a lateral, the more it'll be superimpositioned. Bilateral concavity. All right, we got one more.
PA.
Everybody's done one. Oh, actually, I'll do it because I'm not going to tell you what they would have knew it.
Is this going to be a hand?
Yep, I'll do a hand. Actually, I'll also do an exposure of that, the broken wrist so they can see what real purple face looks like.
The one we just looked at.
Yeah.
You remember what it's called?
Okay.
Yeah.
I'll search that go. Yeah, they're always in oblique.
There we go.
Push the button.
So you can, some of y'all can go with open as well.
So this looks like a TN.
So look at the metacarpal, the MCP joints. I gotta look which one okay. So everybody look at the MCP joints. And then, like, take a good look, and then Mr. Lee, will you flip the other one?
You know it. Okay, so this is the good one. This is the not so good.
Do you see the difference? Yes, do you see, like, you can actually see the underside of the other, the phalanx, the proximal phalanx, do you see that?
Yeah.
So look at the MCP joints, you can't see in them, you can't see through that joint space, you can actually see the underside of that phalanx above the metacarpal, do you see that? And then flip back, will you flip back, Mr. Lee, to
I
the good
will.
one? You see the difference?
There's the good.
You can see the joint space on the,
There's
like
the
the pinky joint space of the MCP is really open. That's a good image. And then on the one that I had a sponge under the fingertips, you can see it's you can see how all those the joint spaces are not open. So I had their fingertips up on a sponge, like a 20-degree sponge or something like that. But that's actually real bones, so you can see all the carpal bones.
Well, this is interesting.
What's interesting?
Okay, look at this. This is the good one. Okay, with the open joints. See that part of the phantom?
Yep.
Okay, on the bad one,
It looks perfect.
it does. It looks like perfectly straight across. What the
That
heck?
is strange.
Did you have the wrist elevated or the fingers
Fingertips.
elevated? Fingertips were elevated.
I had the fingertips elevated.
That's weird.
Yep.
Huh.
The divergence of the ray, maybe.
Okay, that's why I was asking, because if the wrist was up, then it would make sense, because it was more, it would be more in
No.
line with the
I'll
diverging
bring it out
ray.
here and I'll show you what I did.
Okay, this is my X-ray nerd coming through. Okay. Shoot. Okay,
Yeah.
got it. That makes sense now.
Mm-hmm.
Whenever you put that thing flat, it's actually tilted.
Yep, exactly.
That makes sense,
Because it
yeah.
doesn't have fingers. If it had fingers, it would hold itself up. Did everybody see why that did that? But see, there's critical thinking, like something didn't make sense, so we had to figure it out.
Mm-hmm.
All right. So does everybody understand why we want the phalanges or the hand as flat as possible, or at least the fingers for those obliques? If the obliques, if we don't have everything on the same plane, it'll be not open joint space. So on the next